Good afternoon, everyone. I hope that I'm audible enough. Welcome to 2021. Welcome to the COVID-19 Botswana webinar series hosted by Rutgers Global Health Institution. We've had such a rough start to 2021, as most people know. Cases have dramatically increased, both in terms of numbers and deaths, and unfortunately. And we've seen it fit that we must start off the year with this webinar series on oxygen therapy. And just before we kick off, we're going to go over some house rules. This webinar series is co-organized by the Ministry of Health and Wellness, UB, Botswana Health, Harvard Partnership, and Rutgers University. You can join the mailing list by emailing Robert at armumark@yahoo.com. I think it's important that we share this to as many people across the country as possible as we have more webinar series so that we can get the whole country involved. The sessions are on Zoom, as you can see today. Please mute your microphone once the presenter has started, as it results in a lot of echoes, and we're actually not able to hear the presenter properly. If you have questions during the presentation, we prefer that you either use the chat function, and one of the moderator will monitor the question and answer it immediately or at a later time, or you can wait until we have the question and answer series. This is after the session, and then a feedback survey will be emailed, and we would love suggestions on how to improve these sessions, and specifically suggestions on which future webinars or topics we should hold. We have had our previous webinars, as you can see there at the bottom, still hosted by Botswana-Rutgers Partnership. Please do go through this. They are available on the project Echo COVID-19 under Botswana-Rutgers Partnership for Health. The last webinar that we had was on critical care for the non-ICU provider, which is about a month ago. We do have the COVID-19 portal. As you can see, covid19portal.gov.bw. Please do visit this. It has different aspects and the information on the interzonal permit, the zonal map, the data dashboard, documentary library. This is very important as you practice on COVID-19 and you provide family as well as patients advice on especially travel during this time that the pandemic is getting worse. And when you open the portal, you have access to different guides on the document library. Important ones, just to note a few: infection prevention and control on standards of practice. You have quarantine and isolation guidelines. And of course, you have the interim COVID-19 clinical management guideline of Botswana, which will probably change in the next week or two as we incorporate new or emerging treatments in terms of severe COVID pneumonia, as we try to save more lives. Without further ado, I would like to introduce our speaker for today, who is Dr. Makamu Sebakeng. Dr. Sebakeng is a lecturer of emergency medicine at UB, and he's an emergency medicine physician at Sekitumile Masira, as well as Princess Marina Hospital. He's currently based at Sekitumile Masira, and he's the head of emergency medicine. And he's actually leading the response to the pandemic and the emergency department at Sekitumile. He's been dealing with a lot of these sick cases over the past 3 to 4 weeks or so. So it's a pleasure to introduce him to teach and talk to us about oxygen therapy.
Thank you, Dr. Palai. Just a second as I share my other my other screens. Okay, I hope everyone can see it. Good afternoon, ladies and gentlemen. Really, as Dr. Palai has said, the whole point of this discussion is maybe to make ourselves, because the reality is that there's 30 million Masira. We are seeing quite large numbers, and are somewhat struggling to deal with some of them. I think we have obviously come to a point where we need to do a little bit of decentralization of treatment, and it's important for everyone else to become comfortable with the management of some of the patients. There's also the fact that we're receiving a lot of these patients. It will be helpful for them to be, treated, or to be in a condition where they are not peri-arrest upon arrival. So oxygenation is just one of those important issues that we'll talk about. It's hoped that some of my colleagues would also deal with the other issues, including critical care, so other critical care issues such as fluid management and possibly ventilation. So we'll talk a little bit about oxygen. I've tried to make this presentation simple. I've stayed away from what I consider to be quite complicated subjects relating to this, and try to stick with things that are quite clinical. So we'll talk a little bit about oxygen as a drug, how to evaluate oxygenation in our setting, and talk a little bit about how COVID-19 is causing hypoxia. And we'll talk about a few devices, oxygenation devices, and I'll try to stick with what we have here. And we'll talk a little bit about CPAP and BiPAP, and how to escalate to mechanical ventilation. The talk on mechanical ventilation is going to be scheduled for another time. We all know the role of oxygen. I believe it's in the production of ATP, and it is titrated. We usually titrate it to a specific partial pressure of oxygen or saturations of oxygen. And there's different targets depending on the patient types. And its uses are multiple. You could use it in hypoxia, you could use it in shock states for oxygenation, and treatment of some toxicological instances such as carbon monoxide. And in some rare instances, decompression sickness and all those sorts of things. But we'll try to stay away from a lot of those and trying to stick with what is important for us. So for hypoxia, shock, pre-oxygenation of intubated patients, that is where we're most likely going to use it in the space of COVID. It is important to note that there's probably a U-shaped curve mortality with oxygen. The extremes are a bit of a problem. If you have got hypoxia, causes mortality, hyperoxia causes mortality. And the side effects are numerous, but I've just picked a few. One of the more important ones is this release of free radicals if you have someone is hyperoxic. And it has been associated with the poor mortality. There's also a few respiratory side effects like pulmonary vasodilatation, and it is sometimes causes CO2 retention in COPD. Or you can have another phenomenon called the Halden effect. it's quite similar, where the patient is actually retaining carbon dioxide. There's also some immune and cardiovascular and neurological side effects that are well known. The whole point of this is to say that, yes, they do need oxygen, but we just need to know that there is too much of that good thing. The next thing that we'll talk about is how to assess oxygenation. It's one of those things, if you read about it, there's a million formulas, there's a million ways, and there's many complicated methods. But the go-to thing for me is pulse oximetry. It's cheap. I'm sure it's available in most areas. There's no pain. There's very little complex maths that you have to do. Unlike an arterial blood gas, where you first thing you stop and wondering, is this acidosis, is this metabolic, is blah, blah, blah. And it can be a bit of a distraction. So for me, get oxygen saturations. It's a good measure of how oxygen is being delivered to the tissues. And it's one of the ways of accessing oxygenation. There's a few caveats, obviously. You need to be careful. So interpretation is more reliable if you have got a nice waveform on whatever monitor you are using. If you can't get a consistent waveform, that becomes a little bit unreliable. In a patient who's shocked or is very cold, it can also be quite unreliable. In that if there isn't enough circulation to the peripheries, it doesn't do very well. There's also other causes of errors, which I don't think they're all that important. One of the few things that you would know is that just make sure that the patient doesn't have nail polish on their fingers. Make sure that they're not shocked, and then you could be on your way. Yes, it has made headlines that it may be inaccurate for people with pigmented skin, but it is still quite useful, and I would take it over an arterial blood gas any day. So you would only need to do an ABG if you think for some reason that there's some issues with reliability of the pulse oximetry, like I have said earlier. Or if you needed to do an objective calculation such as a PF ratio, which is probably the only math that I would ever advocate for to be done in this talk. We also need to be a bit careful that carbon dioxide retention, and it's probably one of the pitfalls here. Carbon dioxide retention is quite late in amongst the COVID patients. In fact, usually their PCO2 is low or normal until if they are just about to arrest. So stick with pulse oximetry and make a lot of your decision based on pulse oximetry so that you don't overload yourself with information. We are aware that the pathophysiology here is that these patients develop ARDS. While there's no real given target of ARDS, we think it's prudent to target 92 to 98% for a patient with an acute problem, and the 88 to 92 is for COPD or other patients with chronic causes of hypoxia. We need to be careful about the 100%. The relationship between your PaO2 and pulse oximetry disappears as you get at 100%. So it could be just right around the corner at with the PaO2 of 100, but it could be also as far as 300, which is hyperoxic, and this can be harmful. So the trick is to alternate your oxygen delivery methods and flows if necessary, so that you are able to hit the target. I'm one of those people who, from my experience, there's a few times where I would try not to stick to the targets. During transportation, during the short movement from the ambulance from one hospital to another, I would just aim for 100%. because there might be a lot of finicking to do. But as soon as you have a patient who's stable and is in one place, then you can adjust whatever you have to be able to get a good target. So blood gas analysis, I'm not saying there's no role for it. But if you do, in this instance, if you actually wanted to measure arterial sort of oxygenation, then it has to be an arterial blood gas. It's not without its complications, and it's not without its issues, because sometimes arteries are a bit difficult to hit. Sometimes we come up with mixed samples, and it can be useful to calculate that PF ratio. There's many calculations that you can make out of, and I'm sure if there's a pulmonologist here, they'll hate me, out of the measurements that you find there. For me, the PF ratio is the simple one that you'll be able to get a bit more information out of it. But other than that, really try and rely mostly on pulse oximetry in order to make some of these judgments. I've already mentioned the problem with waiting for retention of CO2. That's a bit of a problem. The role of a PF ratio is that it's been used by as a way of estimating the severity of your ARDS. We know that, and it's just a fraction of your partial pressure of oxygen and the FiO2 of the oxygen that you are getting. And if you are below 100, you have quite severe disease. Moderate is between 100 to 200, and 200 to 300 is mild. And obviously, this wasn't based on, when this was developed, it wasn't based on COVID. The other important parameter that we need to look at is the work of breathing. We need to know that patients can become too tired to breathe, and it's one of those things that one of the best parameter or best metric to use, obviously, is the respiratory rate, and it's mostly the how the patient respires. If they just have tachypnea without use of accessory muscles, then you think they'll probably be able to hold on a little bit longer. But now when you start seeing them tripoding with retractions and shallow breaths, paradoxical breathing, that is an indicator of a problem. The other issue that we have seen is that a lot of people do not use, they have multi-parameter monitors, but they never use them to track their respiratory rates. Most of these monitors, you can actually tell it to track respiratory rate, and it will do a good job of doing that. If it does, then you are able to see the increment in respiratory rate of the patient. The patient continues to deteriorate. It continues to have tachypnea. It's actually a sign that you're probably moving in the wrong direction. So it's something that you need to be careful of, and it will give you a good indicator. So a patient might be holding on to a saturation of 88, but the respiratory rate is 75, and they are using every muscle in the body. Obviously, they're not going to last very long. So you can't use pulse oximetry alone there. And then the last, or one of the parameters you can use is mental status. As soon as patients start becoming very restless, and there's no obvious reason why they are that restless, very likely they have life-threatening hypoxia. And you can see the same thing with hypercarbia. But I've told you that in this case, hypercarbia is like that tension pneumothorax that has been diagnosed with an X-ray. You really don't want to get. So how did we end up with this sort of problems? We know, I'm sure we know the background of COVID, what it is. The most important problem is that it attacks this, it binds to this ACE2 receptors that are in the alveoli. And there's also in the intestinal epithelia and in the vascular endothelium, and hence causing the three major types of groups of symptoms: the respiratory, which is the biggest problem, and a few of the intestinal issues as well, and then the vascular issue, which tends to compound the respiratory problem. A lot of our patients do have varying sizes of pulmonary emboli. I hope this project's well. So the patient then goes through or presents with these three syndromes where they have got hypoxemia, which is the main issue, like I've said. And COVID-19 has reduced surfactant levels, and therefore you get a lot of de-recruitment. And then you get this exuberant cytokine reaction and the disseminated intravascular coagulability, and ending up with these PEs. And eventually we've seen a few ischemic strokes as well. And this is the other part that patients go through this. There's several stages. A lot of patients undergo the viral phase, the stage 1, and then they recover. Some get a little bit of stage 2, stage 2A, stage 2B, then they recover. And then the ones that tend to get to stage 3, it becomes a bit of a problem. And these are the ones that sometimes we end up with them here. So that is the challenge. So now you have a patient, you know that your patient has got COVID, either via a PCR or you've got high index of suspicion because of your rapid tests and your imaging. What do you do? The first thing you mostly start with is the humble face mask. And there are differences. Some of the figures that I give here might not necessarily speak to the masks that you have. Some might be a bit more special than the ones that I have. But the oxygen simple face masks, usually they require flow rate of 6 to 12. Some manufacturers might have slightly different recommendations. Please try and stick with the flow rate that is given. Some of these devices, if you crank them more, one of two things happens. The first one is nothing. The patient doesn't get any more flow than what you are saying. And secondly, sometimes the oxygen mask ejects from the gauge. And as we know, a lot of the times these patients are isolated on their own. So if that ejects from the attachment, the patient is just going to become hypoxic without you noticing. So the FiO2 that you could likely get from face masks ranges from 35 to 60, and it has a lot to do with how the patient interacts with the mask. So the patient has got a much higher minute ventilation, they would probably get a little bit more FiO2, but if they have got less or they are hyperventilating, they'll probably get less of that. As soon as you get it and your patient doesn't immediately reach your target, please try to prone them. I've been asked one of the patients how or why proning works. Like a lot of this, nobody is entirely certain, but it seems to prevent a lot of this atelectasis, which we see in this patient. So, and when you do it immediately or within a short time, you see the oxygenation improving. It's much better to make some of these interventions early rather than wait until the patient is confused and hypoxic. Then you try to tell them to prone and they won't follow instructions. So some of these interventions are better done early. If you are using bubble humidifiers, which is a lot of us are using, there's a belief, or there's those that argue that they lose the efficacy of humidifying the oxygen if you run them anywhere below 6 liters per minute. But I would still, you could still use it. The other big problem with it, and this is where there's been a bit of debate over whether or not they are useful, is that when side-by-side researches have been done, whether or not they actually prevent dryness, there isn't a lot of convincing evidence, but there's a lot of stasis and infections from those bottles. So they need to be cleaned. I know that sometimes one patient goes, nobody cleans them, next patient comes and they just get connected, and that water has been recycled for days at a time. So that is one of the things we need to be looking out for. The next thing that we could pick up, and I have a tendency to pick this one first, is the nasal cannula. The nasal cannula has got an advantage of that it is more comfortable for patients, and it's easier to ask a patient to prone if they're on a nasal prong. It does have its limitations. The maximum flow, obviously, you can go there is 6 liters. Anything above 6 liters doesn't make any difference, unless if the manufacturer is otherwise specified. The golden rule is that from 1 liter, so from you get 4% for every 1 liter that you get, that for 1 liter of flow above the atmospheric air. So that if you're pushing 1 liter per minute, you're gonna get 25% and all that up until 6 liters, where you get 45. This is one of those where there's no point cranking it below 6 liters per minute. It might come off, and even still, you are not really effectively using all the oxygen that you're pumping out. So that's the story of the nasal cannula. There are nasal cannulas that have got reservoirs. I don't think we have had them here. Those tend to give a far much higher FiO2 for a lower flow rate. One of the things that you if you are not aware, is that we are experiencing issues with oxygen here in our hospital. I think the update in the morning was that we are running an equivalent of, these large tanks. We are running an equivalent of 100 and something of those per day, and that is a bit of a problem. I think we are lucky that the hospital has got an oxygen generating facility. Otherwise, I don't know where we would be at the moment. So almost every patient is running 15 liters per minute, and some are on high flow systems and running 40 liters per minute. So eventually we would have the problem of oxygen itself. So if we could find ways to conserve it, even in your hospitals. I know that I've seen this in the past. Sometimes patient goes out of the oxygen, or they are no longer requiring it, and nobody shuts it off. So we'll be coming to your facility to come and confiscate your oxygen. So please use it sparingly. So so you have tried the face mask, you have tried a nasal prong, and your patient still isn't getting to where you want them to be. The next thing that you could use is a non-rebreather mask. Those who are in Maun, please get non-rebreather masks. I don't know where you're gonna find them, but please get non-rebreather masks, because it would make such a huge difference. So the estimated FiO2 here goes up to 90%. There's a few things that you need to be careful about, though, with non-rebreather masks. They've been notorious. So sometimes the non-rebreather mask has got valves on both sides. So in both of these valves, so the ones that are on the mask itself, each time you breathe out, they open up, and you try to breathe in, they close, and then the one that is on the reservoir opens up and then allows you to take a breath. So the mask itself is heavily dependent on oxygen supply. So if you put it on a patient, especially a patient who's with abnormal mental status, and you've got one of these ones with a very good, nice, soft seal, if it seals up and the oxygen runs out, the patient is going to suffocate because they are just going to breathe in until the reservoir. So they're going to be dragging air from the reservoir, and then they'll be pushing out through the valves, and they'll do that until the reservoir is empty, and then they'll just suffocate. So it is very, very important that when you're using this, you are careful. That's why some people do remove one of the flaps, one of the valves on top on the mask itself. It's for this particular safety reason. So there is another type of mask that's called a partial rebreather, and it's just an issue of the valves. So the other one doesn't have several valves. So the one would have 3 valves and one would have either no valves or 1 or 2 valves instead. So, and for that reason, there will be a difference in the FiO2 that it gives. That's why there's a range rather than a very specific number. So you have done your mask or nasal prongs, you've done what you can, you move to the non-rebreather mask, you are getting somewhere or it's not getting better. Then what next? The next thing really is high flow nasal oxygen. And I put them side by side by the next, I've ranked them side by side with the next device that I'll talk about in a little bit. So these ones, they allow you to crank up the flows to up to 60 liters per minute. And at some point, this was started from something that was copied from pediatrics. People thought that perhaps they give some level of CPAP. Doesn't look like, because it goes through the nose and it comes out through the mouth, and you can't really argue that you're able to get any sustained level of PEEP. But there's a suggestion that because it goes in such high flow, there's a lot of washout of this excessive air that you breathe out, and such that in the end, your lungs are, when you take in a breath, they're occupied with mostly the warm and humidified oxygen that's coming through. There's a general consensus here, or almost everyone here does humidify the air that comes in and warm them. And there's a number of systems that are out there. I'm unsure what's available in your setting, but usually it requires an oxygen mixer and also a flow meter. It could be a combination of those. So you connect the flow meter or mixer to the wall, and then the gas that it produces, it goes through a humidifier stroke warmer on its way to the patient. And you are able to adjust the flow as well as the FiO2 on the device itself. If you ask me, I often feel that perhaps we could have invested a little bit more on this, because in our hospital here, we are only able to do this using the same ventilators that we use to actually ventilate patients. Those are the systems that we use to do high flow. But they could obviously be cheaper, because you could just use something that just connects to the wall as a mixer, and then you get a warmer, and then you're able to deliver this high flow humidified oxygen to the patient. So from there, like I said, the flow meter goes to an active humidifier and then into a nasal system. There's usually, you connect an IV back to it so that it continuously puts in fluid in there, so that the oxygen that you send to the patient is humidified. As you can imagine, it's 60 liters per minute. The last thing you want is to be pushing dry gas like that into somebody's lungs. So humidification, as well as warming, is very, very important in this instance. There were some concerns initially that this is probably aerosol generating phenomenon, and therefore you spread COVID all over the place. This evidence is very shaky that it does this, and a lot of international bodies do advocate that it can be used as long as you take the appropriate PPE. The problem is, and then the other issue, and it's actually a good advantage to this, is that it's more comfortable for patients than masks. So you find that you've been struggling to prone a patient on a non-rigor mask. You put them on this, they're able to prone. So from there, I mean, you have tried all that, and assuming that you have some of these facilities, the next thing you want to try and do is to give the patients continuous positive airway pressure, or CPAP. Our experience here has been that actually CPAP has been doing way better than high flow. Our intubation rates, even though I couldn't say it from the top of my head, are actually a little bit lower with CPAP than they are with high flow. We have said that atelectasis is a major problem, and that's part of the pathology of the hypoxia itself. So if you give patients CPAP, you try to recruit those collapsed alveoli, and such that you are able to recruit more space for absorption of oxygen. The CPAP doesn't augment the tidal volumes, and therefore it doesn't help with the tired patient. But you could also do a bi-level ventilation. So, which is actually you giving the patients two continuous pressures. One is baseline, and then the other one comes on when the patient takes in a breath. So it's triggered when a patient produces either a negative flow or a negative pressure, and then it kind of gives a supporting breath. So it's called bi-level ventilation, or BiPAP, and that is another way of doing it. It's actually what I prefer. Not really based on much, but I often feel that if it can reduce the work of breathing, because part of the big problem is that by the time the patient gets here, they've been huffing and puffing for days, so they're really quite tired. And if you could find a way to make their body work a little bit less, I'll just jump at the opportunity. It carries a risk of aspiration, and therefore it really needs patients that are awake, that are better than patients that are sedated or with low GCS, and they should be kept at 45 degrees. Yes, sometimes you run into trouble and you have to sedate them to just to get it done, because unfortunately our outcomes for ventilated patients, and that they're not unique to us, they are not great, to say the least. So we do what we can to avoid patients going onto a mechanical ventilator. There's a time when we were doing 50%, but I think now we are much lower than 50%. And by then we had a much lower burden of patients. So there's a few devices out there. The device on the right-hand side, on your right-hand side, we have this here. It works somewhat, but it is quite better than nothing. Some patients actually do well on it. And then the other second option that we've been using is the Draga ventilator that you see on your left. It's already, if you look very closely on it, it's actually connected to a high flow system that I've been talking about earlier. The other issue is that the Oxylog 3000, which I've seen in a lot of hospitals being used as a transport ventilator, can provide both CPAP and BiPAP. It looks something like this. If you look on your right-hand side where there's cancelled bell, there is the PC BiPAP, which is pressure controlled BiPAP. And then next to it is spontaneous or CPAP. So you can enter any of those modes. If you look at right now, it hasn't been properly set, but it's already saying PEEP at 5 bar or 5 centimeters of water. Millimeter bar and centimeters of water is roughly almost the same thing. Or you can use the spontaneous or CPAP mode on the other side, and then you can get it hooked onto the patient. The problem is with the masks. So you might have seen the mask here. So you really need these interfaces. So it's either you use a mask like this, or you use a helmet mask that you have seen in Italy. I often wish that people would be trying to invent that rather than a new ventilator, which not meaning to discourage anyone, but it would be far much better for people to be doing simpler things. I like simpler things. So a helmet CPAP, for instance, would help us with a lot of the patients who are quite claustrophobic, and you could easily just connect that to the patient and be able to provide CPAP or BiPAP with it. So I have spoken a little bit about this. So how do you do it? Well, CPAP. Sometimes you like today I got a patient who said he's already on CPAP at home. So it's quite a bless. So you very quickly they're able to adapt to it, and then they tell you the pressure that their machine usually starts at 5, and then within 15 minutes it ramps up to 15, and then you do exactly what the patient says. So you just have to ramp it, and your target here is your saturations, 92 to 98, leave it there. And then you can leave it on the patient for 24 to 48 hours and see what happens. While BiPAP, on the other hand, so there's two pressures here that I've said. The other one, the EPAP, is actually the CPAP or the PEEP. So you can start at 4 and 8. And these numbers are, to be frank with you, is mostly a suck of the thumb. I don't think anyone has done in some research to say that 4 is better than 5, or I could be wrong. But I like to start at 4 and 8, and then you just do minimal increments. You'll be surprised, some patients at a PEEP of 7, they go up to 90, 95%, and then you're able to leave them there. You can actually increase it slightly to a maximum of about 20 for the IPAP. Here you are aiming for a tidal volume, and some of these machines are able to measure tidal volume for you, and therefore you can be able to have an aim. Other than that, just if your machine doesn't give you feedback on the tidal volume, you just crank it up until your patient is doing much better, work of breathing is less, and the saturations are where you want them. One of the things you could tell early on is that if your patient has got if the PaO2 after 1 hour, they are failing to get above 150, your ratio, then very likely to fail your non-invasive interventions, and therefore you unfortunately would have to escalate it to ventilation. So the other tricky part is sedating patients on a non-invasive ventilation. It's one of those things that I don't like to do. I beg patients, I ask them nicely to tolerate the systems, because as soon as they are able to tolerate it, they can just sit there for hours and just chug on. But if you have to sedate them, it can be a bit of a challenge, and those are the options. You could use ketamine, but it will wear off very quickly, or the patient might throw up. So that's the other issue with fentanyl, also with ketamine. The other options is to be giving them smaller doses of fentanyl, hoping that they'll eventually get used to it, or benzodiazepines. But you can get all kinds of funny things with benzodiazepines, paradoxical reactions, even though there are not that many. But try to talk to them. Some patients are just claustrophobic, and eventually they get better. And sometimes they are just hypoxic. And if you are able to keep them there long enough for them to fix their hypoxia, they tend to be a little bit more understanding. Your goal is to do non-invasive ventilation for 24 to 48 hours until you get clinical improvement. The likelihood is that you would see early on that your patient is moving in the right direction. If you what I do is that if my CPAP or the EPAP is now at 4 and the patient is able to oxygenate well, and that's the time to stop doing it. Or patient's respiratory rate comes to below 30 and a PO2 of 60, FiO2 of 30 without a respiratory distress, then you can be able to win them. So when do you ventilate? This is a very tough one. So there is no magic cutoff for the SpO2, but if you are not maintaining more than 80, yeah, people should start thinking of finding ways to intubate you. It's also important to tell between a patient who's just tachypneic versus one with a respiratory distress, because it is easy to just, if it's a fitter young man like we've been seeing lately, we've been getting a lot of younger people, and he just has a very high respiratory rate. Very likely he has a bit of a reserve that he can be able to maintain that without having a tube down his throat and worsening his prognosis. So the respiratory distress and work of breathing is one of your consideration. And thirdly, the trajectory. You need to watch where the patient is going. And this is why monitoring is very, very important. I have mentioned earlier that, a lot of us, we might have well, not all of us, but if you do have a multi-parameter monitor, then put it on the patient. That way, then you can tell it to cycle blood pressure, for instance, to monitor respiratory rate, to monitor SpO2. And then when you come back later, it's easy for you to look back and see how the patient has been doing. And you can be able to make decisions out of this. There's more. I've already said that if you intubate the patients, the outcome is not great. And if you intubate them when they are very hypoxic, it's a bit of a problem. And then if you leave the hospital, go into the road or go into an aircraft, and then midway you try to intubate, it will be a bit of a problem. If you are going to go on an aircraft, remember aircrafts, they don't pressurize ground level. So as they rise, they kind of reduce the pressure slightly to about a pressure level of 8,000 feet. And that could make patients who are with baseline hypoxia a little bit worse. So it's one of those considerations that you need to make. So it is ultimately up to the clinician to make that decision. If you need to make your decision, make it early and act on it. You need to be decisive, but obviously not to rush the decision. I hope I'm not confusing you. You need to obviously keep in mind that if they are intubated, the prognosis is not so great, but what is the risk that the patient has? So this is what I've been saying. So do your SpO2, start the patient on a face mask or nasal prong as they arrive. Keep them prone. So there's another technique that I think I've used during training. I've tried to find evidence for it because I used to think that there was a lot of evidence for it, but I couldn't find it. Perhaps I should have written it when I had the chance. Was to use nasal prongs, and then you put a non-rebreather mask on top. I thought it worked. It used to improve somewhat. The problem is the patient needs to have 2 sources of oxygen that are running at, that patient will be eating at least 26 liters of your 50-liter tank every hour. So that is the bit of a problem with it. But if you have CPAP or high flow systems, bring them in, and if you really have to, you can intubate. you have to also be careful about the sort of patient you intubate. If your patient, for instance, and we know this from data from elsewhere, if your patient requires mechanical ventilation and say dialysis as well, we know that their outcomes are not that great. If you intubate an 89-year-old patient, the outcomes is not so great. If you want to intubate patient with a very poor baseline, who has been bedridden, hasn't walked in the past year, really, it's a bit of a problem, because remember, we need these ICU beds. We have been getting, and I know it's one of the questions that I've got. What is the sort of patients that we have, and what are the proportions? Earlier on in the pandemic, we had mostly older patients, and not that many patients that were very sick. The proportions of the very sick was low. We could use one high dependence. And then with time, what has happened is that we've got more sick patients, more of the older patients, but there's also been an addition of the younger patients. Younger, I mean in their 30s and 40s. Some of them, their only comorbidity is a bit of an increased BMI. Well, some, we make effects diagnosis of diabetes here. But that's the trend we are going. So we have more patients and sicker younger patients. So we need to be quite judicious in how we use some of the resources. Then this was the end of my presentations. This is a few things you need to be on the lookout for. I said, so there is a phenomenon called happy hypoxia, and it has been a bit of a problem for us in the past, where your patient saturation is 60 and they look quite chilled. They are, they're talking to you, they have just mild respiratory distress. They don't look like your typical 60% patient. But when they go down, they just go down just like that. So you need to be on the lookout for this. If a patient is hypoxic, they are hypoxic, something needs to be done about it. I've already spoken about CPAP and BiPAP, and that there's a risk of vomiting, and that you're prone early. And early action, people need to act early. I mean, I've received referrals, I'm not going to mention from where patients tend to come at night and are quite distressed, and you can tell that this patient probably during the day was showing signs that they were deteriorating. It would be better if they came during the day, so I can get some sleep at night, people. And then a few things. So I have also said that I was not going to put a lot of equations, but let me just slide in this one. It's the question of rate of oxygen delivery. And you can ignore most things except for the few that I'm going to point at. You might see that the first one is cardiac output. So you need to kind of put an eye on that, because sometimes we concentrate too much on oxygen and then we don't concentrate on cardiac output. Remember, and there's two issues to this. One, patients have got a quite high work of breathing. They are sweating so much and are losing fluids. And when you actually evaluate them for fluid status, you find that they're quite low. Two, some of these patients have some myocarditis, and therefore they tend to have a decreased cardiac output. So be on the lookout for this. Just know that your oxygen delivery is dependent on your cardiac output. There's also the issue of hemoglobin as well. So your anemic patients, just make sure that you transfuse them, but just up to 10. Yeah, that's about it with this equation. And those are my references. Thank you. Let me bring up the questions and then I can.
All right. Wow. Thank you, Dr. Sebakeng, for such an informative talk. quite detailed. So I think everybody saw that there is a lot that we can use, and the issue really remains what is available where. But I think we can make some adjustments to ensure that most of our patients are somewhat cared for in terms of oxygen requirements, especially knowing that some or most clinics won't have these devices. It's time for questions, answers, and answers, as well as discussion points. I have seen already in the chat box with a point that I thought was quite interesting. We have received calls and we've advised rebreather mask. There's actually videos on how to make non-rebreather mask using a urinary bags. And in fact, I always advise medical officers or physicians across the country that most of our nurses, actually experienced nurses, know how to make a non-rebreather mask. So that's always an option if it's not available at the site. Lots of questions will be coming in the chat box, and we will try to answer them as we go through. But I guess at this point, anybody who has a question for Dr. Sebakeng? Okay. We'll go through the ones that have been asked before, and I'll give Dr. Sebakeng to actually go through these to make time. As it is, we are behind time already.
All right, so I'll try to go through some of them as quickly as I can, and some of them I may not have answers to. So the first question is COVID-19 treatment guide. When is it available? So it is available. Yeah. So it is available online, like as you have been shown.
It's going to be
so yeah. So and it will be revised. The next one is, does high flow oxygen therapy prevent the need for intubation? The evidence suggests so. In fact, that is why it's been advocated. In our experience, yes, there's been 1 or 2 instances where it has been successful, and we were able to prevent intubations. But yeah, sometimes patients fail and they go ahead to intubation. And like we've said, that the intubation's prognosis is a bit of a problem. Does the need for oxygen therapy somewhat affect the prognosis of the patient? Yes, it does. The higher your requirement, obviously, the more likely your outcomes is gonna be a problem. Then the next question was the demand of oxygen. And then is Botswana prepared? I mean, it's quite a tough question that I can't, probably slightly beyond me. But like I've said, that there is, even in the best of instances, oxygen has become a problem. We do what we can to make sure that we minimize as much as possible. I know in other countries they've stopped elective surgery, and in South Africa, for instance, because the trauma has gone down, it's been helping them in that oxygen is just being used for the patients that really need it. For purpose of safety, I've mentioned earlier that our consumption has gone through the roof. It was something that I think the estimate was that we are using an equivalent of, the large oxygen cylinders, more than 100 of them per day. So that is quite a lot. But the good thing is that the hospital has an oxygen generator, so it's able to concentrate oxygen from the air. Yes, we will likely run into trouble, and it's one of those things that is scary. Indications for O2 in a oxygen administration and limited resource area. Look, if your patient is hypoxic, they need oxygen. If you don't fix their hypoxia, they are not going to make it. It's as simple as that. Could you find yourself rationalizing between patients? Yeah, most likely. As with all other health resources during crunch times, you find yourself rationalizing who really needs it. So it's one of those things. Inhalation therapies, that one, the evidence is a bit shaky. So I try to find, so there isn't a lot of very good quality evidence, but there are people who swear by it. And if you are Botswana, you would know that when we were young, we inhaled a lot of these plants whenever we had a flu. Could it be harmful? Possibly. We had a patient the other day who had a lot of irritation after they got a diagnosis, and they were inhaling everything that they could get their hands on. So it can be a bit of a problem. The next thing is IPC when shared oxygen cylinders and flow meters. Yes, it's better if you cohort your patients. So the oxygen cylinders that's being used by COVID patients remain for COVID patients. And you try not to mix it with other patients. But yes, if push comes to shove, you might end up there. There's even instances where patients have shared ventilators in other countries. So it's an area where you don't want to come to, but it is a possibility. And then, is there already a COVID-19 treatment protocol that almost every country can use? I mean, they all come as recommendations. You take what you can. You may not be able to do what is being recommended. So there's a lot of recommendations that you need to take what you can. Then the other issue is that is supply of oxygen a resource for, I think I've addressed the issue of oxygen. Is there a plan to capacity in the districts in terms of case management? Yes, this is part of the plan. This is why we are here. We are trying to do our part from the standpoint of an academic institution. It's better if other areas can be able to manage their patients. One of the things that people are a bit afraid to manage cases, and that probably leads to poor outcomes. So we need to be capacitated in to deal with that. Now that infection and facilities are increasing, what is the plan to start vaccination? So the vaccination one, I'll leave that one out. I think I don't have the information regarding vaccination for now. To my knowledge, as you are aware, Botswana has procured vaccinations as part of the COVAX, arrangement. When they're going to be coming, we don't know. And then there's a question regarding O2 therapy and humidification. I think I've addressed this one earlier. What are the most dangerous signs for patients in home isolations that I should ask if there are going to be so many? So this one, I think, is quite a good question. And I wish I had very good answers for it. That you have a lot of patients who are on home isolation. What should you tell them to look out for? The biggest issue has been just the hypoxia. So they progressively become hypoxic. Or sometimes they don't notice that they are hypoxic. They just notice that they're a bit clumsy, they're a bit tired. And when they come to hospital, that's when you see some of these things. So it is a bit difficult to tell you what is the smoking gun really, but hypoxia in terms of patients feeling that they're short of breath and they have to work a bit harder for every breath. What can I do when a patient has increased shortness of breath despite being on continuous O2 therapy? I think this is what the lecture was addressing. So you escalate to as much as you can and within the resources, and obviously prudently. Like we said, that patients who are poor prognosis, you can only escalate so far. And then vaccination strategy, that one I'll leave it to others. Current admission rates that need oxygen. I'll leave this one to, I don't know if Dr. Gaolathe will be able to respond to this one. I think I'll give her the opportunity to address this because there's like 2 more questions left. Then what would be helpful to have, would indeed be helpful to have a protocol for home management of COVID disease? I think there is some. Yeah, so there is some. So a lot of these DHMTs, when they do home visit, they do advise patients on how to handle themselves. There's obviously a problem if you talk about Gaborone, that I think the numbers are quite high, and they are kind of exceeding, because I think we are diagnosing 100 or so or more. In the Gaborone area alone, I think we are more than 100 to 200. So it is not possible that they will be able to follow each and every person to their house to go and tell them what to do and test their kids and everything. And I wish I had a good answer to this one. I'll hand over to Dr. Gaolathe to deal with the matter of statistics.
Thank you. Dr. Sebakeng has answered most of your question. Possibly Dr. Palai could have answered this. But of late, our statistics have actually risen. It's more of a yo-yo. We closed before Christmas at about 37, 40 patients in the ward, after a season where we had greater than 200 in the ward before the district health management team opened its isolation centers, where currently we've been averaging about 104 since the holidays. And what we are seeing a greater sicker population. And really our 2 big measurements has been around the hypoxia. We have our ICU to capacity, and really about 15 to 20% on oxygen in the isolation units. And you will appreciate that some of them are managed in the high dependency units. So basically that is where we are currently. We are also seeing a younger group presenting, and we are, of the sickest, getting more referrals from the north. I think notably disturbing from the Maung area. So I think this lecture has been opportune in terms of updating all. There have been a few questions also in the chat box in terms of how the districts will be facilitated. I think really it is also up to us as physicians to do audits in our facilities. Actually, there is more than you'd like to believe in your facilities if only you knew what to do with some of the equipment and the gadgets there. So I think we will be giving support to some of those facilities instead of getting calls of panic and ready to intubate without the necessary escalation. We also have Dr. Palai here, our pulmonary fellow in the making, and he has been instrumental in manning the critical care aspect on the isolation floors.
Yeah, thanks, Dr. Gaolathe. And just to add on, I think if you look through the COVID-19 updates from the Presidential Task Force, just before we left for Christmas, the deaths were just sitting at around 37, 38. Come 4 weeks later, we are sitting at 105. They'll probably be on TV today. And if you look at the pattern, we're looking at sitting at around 120. 120 or more. We've been getting about 12 deaths. I think what one needs to appreciate is that we clearly have not reached the peak of this second wave. Things are only going to get worse. So it's before they get better. So it's important that people in these areas that Dr. Gaolathe has mentioned, Maung, Francistown, Pique, of recent Mahalape and Palape, also now they have become red zones. They need to be really prepared and have measures either to have through Ministry of Health to have these oxygen delivery devices to whatever capacity that they can. If they cannot, they need to capacitate then their team to try to or intensivists, they need to get 19 response, very sick, and unfortunately most either die en route or die immediately upon being received at the emergency room or in the wards. I will take this opportunity to take questions from or somebody from the audience, but we only have 5 minutes. No questions? I see one here. I'm just going to respond to one. Can double barreling work on both CPAP and non-rebreather mask? Dr. Sebakeng says no. I actually have no experience with such, but Dr. Sebakeng says no.
Yeah. So the problem with CPAP, you need to have a good seal. So as soon as you put anything under, you are going to compromise your seal. So that's why really, I mean, it's CPAP alone is superior to double barreling and masks. So if I was to move to CPAP, I'll just do CPAP.
Thanks, Dr. Sebakeng. Any more questions? Remember this this webinar recorded and it will be shared. I believe somebody asked if these slides can well, Dr. Sebakeng.
I have no problem.
Okay, Dr. Sebakeng will also is happy to share these slides so that they can be used on relative districts, clinics for teaching and capacitating healthcare workers in the districts. Question? I don't think there's any more to do.
Thank you. I think we're coming to the end of this session. And thank you, Dr. Sebakeng. We will be having sessions on Monday and Thursdays for the next 2 weeks on the highly critical issues. On Thursday, we'll have Dr. Alexei, intensivist at MBChB Teaching Hospital, present on fluid resuscitation. And the following Monday, we will have Professor Farai Madzibamoto present on ventilation. I'm hoping also as a takeaway for us in the district facilities, just to do a quick and dirty inventory. And we would also like to get feedback so that we work on how we can support all of you out there. With that said, thank you for joining us today, and we will see you on Thursday.